Director of the National Bone Health Alliance, and really want to welcome you to today's webinar that features Dr. Mary Oates from Marion Medical Center talking about setting up a fracture liaison service program. Just a few slides I want to show before I turn it over to Dr. Oates. Next, please. There we go. Just a little bit about MBHA to make sure everyone has a good background on us. So we were launched in late 2010 as a public-private partnership that brings together the resources of our public-private nonprofit partners. We have 55 organizations around the table, 30 nonprofits, 20 private sector members, and 5 government agency liaisons. Really, our goal is to address the priorities of the Bone Health Summit National Action Plan, which includes promoting bone health and preventing disease, improving diagnosis and treatment, and enhancing research, surveillance, and evaluation. Next slide, please. So MBHA is a platform to use our collective voice and membership base to weigh in on subjects including vitamin D and calcium, bone density testing, reimbursement utilization, and the benefit risk of the use of various bone health therapies and other interventions, as well as communicating among individuals and organizations interested in bone health, identifying shared priorities and projects to become reality through shared funding pools, and working toward the goals and recommendations of the 2009 National Action Plan on Bone Health. Next. It's just a list of our, huge list of our members, 50 members and 5 government liaisons, as I mentioned, Center, who you'll hear from in a few minutes. Next slide, can just keep shifting through these. And so really, very early in the organization of MBHA, we kind of laid out this 2020 vision, reducing bone breaks 20% by the year 2020, and really see the fracture liaison service model as the mechanism to do that. Next slide, please. So, you know, among the many tools and resources that we have developed around the fracture liaison service model, which I'm sure you're all familiar with, is our Fracture Prevention Center resource, which is now about, I guess we've had it up for about 3 years now, and more than 3,600 folks have accessed those tools in the last few years. We have now over 30 webinars online, a variety of resources around the business case, how you set up an FLS, how you make the case with some of the other members of the care team, et cetera. And I think it's, you know, it's been very well received. And as we hear feedback from folks on what other tools and resources they need, we certainly try to create and provide those to the field. So go to the next slide, please. So this is just a little bit more about the fracture liaison service, I guess, module or portal that we have up on Fracture Prevention Central, which, as everyone knows, I think, is free to access. So we're really pleased to be able to provide these tools to the community, and really thank our funders to date, Amgen and Eli Lilly, in helping us have the funding support to be able to do so. Next slide. So this is just a listing of our upcoming webinars. It's not a slow summer around MBHA. We have a number of webinars coming up. Obviously, the webinar today on setting up an FLS. I'm really excited about the one that will be this coming Thursday on the Fracture Liaison Service Return on Investment Calculator we've been working on for probably the last couple of years, and we now have the claims data that we needed to power it. We will push this out on Thursday right before the webinar, and then we'll be pleased to provide more details on how you use the calculator to folks on the webinar, and certainly once that's on demand as well will be a good tool to understand what data you need to input into the calculator, and the kinds of outputs that you can use to help make your business case for your fracture liaison service. And then, as you can see, August 4th, billing and coding tools for your FLS. August 16th, something we're doing in collaboration with the International Osteoporosis Foundation, which is how to get best practice recognition for your FLS, which is a program that Capture the Fracture, the IOF FLS portal sponsors, which enables you to get mapped on the international map, your individual FLS, and I can tell you there's only maybe 30 or 40 U.S. programs mapped, so we would love to see many more bronze, silver, and gold stars. And then the last one coming up a little in the fall, October 11th, patient materials for diverse patient populations. So as you can see, all the webinars are available on demand, either on the MBHA Fracture Prevention Central page, or we also have a separate YouTube page that all of them are in the same place. Next slide. And then just a little bit about the one-on-one FLS consult service that I guess we've been running for about a year now, which is also available at no cost. You know, we're really hearing from folks, next slide, that, you know, they were hitting certain roadblocks in their FLS implementation, be it understanding the reimbursement landscape or making the business case or, you know, registry tools and other mechanisms to follow their patients through the FLS process. So really pleased that we were able to launch this program about a year ago to get one-on-one help with FLS programs along with national experts like Dr. Oates, Dr. Andrea Singer, Dr. Anna Lake, and others to really be able to brainstorm and help figure out ways around whatever that roadblock or roadblocks may be. Next, please. So really very easy to arrange a consult. If you know, once you have you've registered for Fracture Prevention Central, there is a page on the website and also on the front page of Fracture Prevention Central, just a small little intake form you need to fill out so that we make sure that we pair you with the right experts, and then we will work with you to facilitate a conversation, either over the phone, via Skype, or in the case of national meetings that folks may be at, we can also arrange to help get you face-to-face time with some of these experts. Next slide. So just before we get started on the webinar, all the attendees will be muted during Dr. Oates' talk. We'll have time for Q&A at the end of the webinar. If you have any questions you'd like to have asked, go to your GoToWebinar panel and you'll see a little icon to be able to type in your question. We will record this, and as I said, for all the other previous webinars, that will be sent around. Usually it takes about a week to turn around, but we'll have that online and on the YouTube page very quickly. And, you know, we'd be pleased for you to let other folks know about this webinar, and you know, we'll continue to communicate around it. I guess one thing before I move over to Dr. Oates as well, one piece I failed to mention is that we also pushed out about 3 weeks ago a national survey on FLS programs, and which you should have received if you're a Fracture Prevention Central registrant. But you know, really our goal there is to try to document the number of active FLS programs in the U.S. It's a very short survey, so if you have not completed it yet, we'd love to get you to send it to us. I know the deadline is this coming Friday. Maybe what I can do is ask Andrea to push out the link again just to make sure everyone has it. So it would be great if you could participate in that and fill that out. Next slide. All right, great. Well, now the main event. So Dr. Mary Oates will be speaking today. She is a board-certified physical medicine and rehab specialist, has been specializing in the diagnosis and treatment of osteoporosis since 1994, and is also a certified clinical densitometrist, as well as a board-certified in electrodiagnostic medicine. She's been working at Marion, French and Arroyo Grande Hospital since 1994, and also has an office in the Pacific Central Coast Health Centers in Santa Maria and San Luis Obispo. And she founded the Marion and French Hospital Osteoporosis Centers and is a volunteer faculty member at Cal Poly State University. Her clinical practice in Santa Maria, California focuses on also the evaluation of nerve and muscle disorders with EMG and nerve conduction studies. She's actively involved with community education and outreach projects aiming at prevention and treatment of diagnosis. She has participated in several osteoporosis research studies, as well as observational body comp studies using DEXA for the evaluation of bone, muscle, and fat. She's currently co-chair of the National Osteoporosis Foundation's annual meeting committee, as well as the ISCD body composition program. She is a graduate of Ohio State University and the University of California Irvine residency program in physical medicine and rehab, really great national expert on FLS. I've really enjoyed working with Mary over the years, and I'm really introduced her to the group. Thanks so much, Mary. Thank you.
All right. Can you hear me, David and Andrea?
Yep.
Okay, so Andrea's going to hand over the controls to me, and I will get started with the main event. I would like to tell you that there are extra slides in this slide deck that you'll be able to see when we, let's see here. Extra slides that you'll be able to see when the PowerPoint presentation is converted to a PDF and sent out to you. So I've got lots of extra background slides that we'll go through quickly, but you'll have a chance to review them later on. So here's my disclosures. And I'd like to briefly go over our objectives for today. Since most of you are on this phone call, you recognize the need for closing the care gap we have for osteoporosis-associated fractures. I'd like to go over the crucial components necessary to start a fracture liaison service. I want you to think about alignments or cultivating relationships in the institutions you're already in, and the value of coordinating with team members in an osteoporosis program. And I'm not going to spend a lot of time on the metrics, but again, I'll be giving you the background information that you'll need to look at how you can quantitate your baseline statistics and improvement and submit those for possible incentive payments from insurers, or in the future to avoid basically having money withheld. So let's go to the care gap for osteoporosis-associated fractures. And I think first I want to start by introducing that term, osteoporosis-associated fractures. I think is the best term that we can use, because terms like fragility fractures or broken bones don't really indicate that we're talking about a fracture that occurred due to underlying osteoporosis. And so we have to look at the context that about 10 million Americans have osteoporosis, with an additional 44 million having low bone mass. And what that means in data in 2005 is there were 2 million Americans that suffered osteoporosis-associated fractures. And that is estimated to increase to the cost of $25 billion in 2025. Women account for 71% of the fractures, and you can see that there's a distribution of vertebral, wrist fractures, hip fractures, pelvic fractures, and other fractures that make up this mix. So why do we care about the first fracture? We care about the first fracture, number one, because from an individual and clinical viewpoint, this really impacts people's independence, their mobility, and their quality of life. But we need to look at it as a red flag, because suffering one fragility fracture, which is defined as breaking a bone from a standing height, increases the risk of an additional fracture by 1.5 to 2 times. So this has to be our red flag. And if you look at it in the opposite direction, approximately 8% of hip fracture patients will go on to have a second hip fracture, okay? So what this means is fracture begets fracture. But really, that's only if it's left untreated. So as I said, from an individual and clinical standpoint, this is an actual patient of mine who had repeated vertebral compression fractures, repeated interventions with kyphoplasty, and nobody addressed her underlying bone status, and nobody told her that that needed to be addressed. So this leaves us with an unbelievable opportunity to identify these patients and initiate treatment. So that was an individual who I care for. But let's look at what the insurers are seeing. This is data from the Midwest, and it's from 2012, 2013. 2013. And what we're really looking at here is that we are doing an extremely poor job of managing osteoporosis-associated fractures compared to standard medical care that we agree upon for a beta blocker after a myocardial infarction, for breast cancer screening. Those aggregate treatment rates are in the realm of 65 to 88%, and we have this horrible 15% treatment rate for caring for osteoporosis-associated fractures. So just last week, our friends at AARP and the health team published their review, and they found basically the exact same information in their large retrospective study. And what they found was that fewer than 1 in 5 women, so that's less than 20%, ages 50 and older, who experienced a hip fracture, utilized the recommended osteoporosis-related services within 6 months. And it got worse as the patients got older. So if they were older than 80, they were even 34% less likely to receive treatment. And if you go one step further and you look at their failure to undergo bone density testing or begin taking a medication, was associated with a 62% increase in a risk of a second hip fracture among women ages 80 and older. So we have this unbelievable opportunity. That's what my husband calls it. He's a physician also. And when we see a quality improvement opportunity, we have to seize the opportunity to act on it. And so this is a quote from the National Bone Health Alliance, Fracture Prevention Central, about how we can and should reduce the likelihood of the occurrence of a second and subsequent fracture, particularly of the hip, because of the morbidity and mortality associated with it. So what's our definition of a fracture liaison service? The fracture liaison service is a coordinated care model that operates under the supervision of specialists and collaborates with the primary care physician. What we're looking to do is to identify and diagnose and treat the likely underlying osteoporosis associated with the fracture. And we want to establish a registry, a process, and a timeline for patient assessment and follow-up care. And of course, since I'm a physical medicine and rehab doctor, I also want to make sure that we eventually get that patient to a falls prevention service. So the basis for this movement began in 2008 when the Joint Commission published this document called Improving and Measuring Osteoporosis Management. And the web link is listed at the bottom of the slide, because really this is where the Bible started for osteoporosis-associated fractures. It contains the framework, sample programming, and all the metrics, although those were ICD-9, and I'll show you how to get the ICD-10 now. Our friends at ASBM&R published Making the First Fracture the Last Fracture, their task report on secondary fracture prevention, and it's a very thorough background and scientific review of the basis for having a coordinated fracture liaison service. And again, there's a web link here because if you get the online version, you have access to a lot of additional information in the appendix. So what are the functions that we are seeking to provide? We want to identify the osteoporosis fractures. We want to investigate secondary causes and assign a risk assessment. We want to initiate appropriate treatment, monitor treatment compliance and adherence, monitor ongoing risk, because patient's risk is not static. It can be very dynamic. And hopefully this will result in fewer fractures, fewer hospitalizations, less cost, less morbidity, less mortality, and better quality of life. So now we're going to go through the steps to start a fracture liaison service. And really where you need to start is to assess your situation. Are you working in a hospital, in an office? Are you a solo practitioner? Do Do you have a coordinator? Do you have a physician champion? And what about the financial arrangements? I'm going to suggest you look for similar disease management programs because I am not a big fan of reinventing the wheel. We're going to talk about how you're going to identify your fragility fractures. We will talk about the evaluation and treatment options that you have within your institution. I'll explain how you can calculate your baseline performance, choose a method for risk assessment, initiate a fall risk assessment and a falls plan, basically a corrective falls plan, talk about treatment, communicating with your providers, and choosing a registry to handle all of this data. So number one, are you hospital-based? Are you a group office? Are you a solo clinician? That's really, really going to influence how you approach this. Again, in your specialty, are you a primary care doctor and you have a large patient population with access to a lot of their preventive care data? Are you an orthopedic group who only sees the patients when they fracture? Are you associated with skilled nursing facilities or acute rehab facilities where you, again, see the patients after fractures? And then the usual players such as rheumatology and endocrinology that have been very involved and leaders in the osteoporosis field for a long time, rheumatologists and endocrinologists. And then a really basic question to ask is, do you have supportive administration? Do they have any idea that there is this huge care gap and that there is a need to fill it? You'll also need to identify a champion because this is a very long process and you have to have someone that has the passion and the enthusiasm to drive it through your system. And then, of course, we have the reality of a budget. So I don't want to steal David's thunder for the webinar on Thursday, but I have a couple screenshots just to whet your appetite about the return on investment calculator. And basically, as David said, this has been a very long project, but now we have a workable, interactive spreadsheet that will let you put in information about the number of fragility fractures that you're seeing. It makes assumptions about the recruitment rate, patients you'll be able to pull into your program. It makes assumptions about staffing. And then it lets you walk through your cost for running that program for that volume of patients. And then it will also ask you to put in services that your institution can provide to see what revenue you can generate by your fracture liaison services. So basically, if you're identifying the patient and you're doing a good job of standard care, this would enable you to see if you're going to have a net profit, a neutral program, or a net loss. And in our experience, providing the right care actually generates additional revenue. And so then, using claims data, it will also let you look at the costs associated with fractures in your institution. And then if you look here in the light blue, the costs avoided due to the fracture liaison service program. So as I said before, you may also want to, instead of starting from scratch, going to your institution, pitching the idea, you probably want to do some reconnaissance and first look around and see what similar programs you have in your institution or community. So, for example, in our Dignity Health system, we have nurse navigators. We have special nurse navigators assigned for breast cancer and prostate cancer, for the lung cancer screening program, diabetes nurse educator, and our congestive heart failure program. So there is a precedent, there is infrastructure, and there's a historical budget and a historical acceptance of these preventive programs. Now, how do you even begin to get started? What you're going to do is you're going to take this link, and these are the ICD-10 fracture codes that you are going to want to give to your IT person, whether it's your billing IT person or your electronic medical record IT person. These are the ICD-10 fracture codes that you're going to query your system for to identify your patients, okay? So prior to March, it was a crosswalk after ICD-9 and it was a mess, and now the ICD-10 is available. Okay, so this is where you're gonna start. Then you're going to say, if I can identify those patients, what resources in my institution can I also query to see if we've been providing evaluation and treatment? So for example, I have access to a DEXA scan, a QCT scan, infusion services, physical therapy. We have a new balance evaluation and training program, and we have home health services. So I'm going to give those codes or also query those services to see if we are providing those services, which are standard of care, to the patients that have been identified with fragility fractures. So this is a very old screenshot of how we started. And basically, we had to query our system for those fracture codes and look to see how well we were doing at offering the secondary evaluations, treatment, and DEXA scans. And the truth is, we were identifying all the patients, but we were doing a below standard job of getting treatment initiated. So for those of you that are already overwhelmed by thinking about how you're going to query your system, this is the slide that you need. This is the electronic medical record data or your billing data that you need to run your query. So it's going to be the query for the fracture codes. You're going to want to look at the secondary causes with the BUN, creatinine, calcium, 25-hydroxyvitamin D, and LFTs. You're going to want to put in the generic names for all these medications to see if they were given in your medication administration record or your MARS. You're going to want to query for DEXA, fall risk assessment, fracture liaison consult, and then somewhere in the nursing records, smoking cessation and patient education. You're also going to want to decide how you're going to assign risk. And if the patient cannot be transported for a DEXA or a QCT, which rarely they can, I mean, I've actually never had a patient acutely hospitalized that was able to do that. You can do a FRAX calculation, a Garvin calculation. You can do a heel ultrasound or a wrist ultrasound. And very importantly, this bottom bullet says if you're unable to complete a risk assessment, document why it could not be completed. And this is an important point because if you're going to apply or send in your metrics to your insurers, then you still get credit for providing a risk assessment even though it was unable to be completed if you can document why. So this is what we do. We do a wrist ultrasound in our skilled nursing facility patients and inpatients because it's easy, and if the patient's immobilized or in pain, it doesn't impact them. And we have been able to scan 1,000 patients in our skilled nursing facility by using this method. So we also have to talk about initiating a fall assessment or fall plan and lifestyle changes. And so in our institution, we begin that in the inpatient setting and with a video education. And so the doctor can order it, the discharge planner can order it, the nurses can order these videos to be played on their TV screen. And you can see here we've got treating osteoporosis, fall prevention, and bone health. Okay, so any patient with a fragility fracture will automatically have these videos looping on their TV. And then, as you all know, we've got to avoid the fall, right? And so being a physical medicine and rehabilitation doctor and having a really wonderful physical therapist who believes in this program, we are working to offer fall prevention resources at many different levels. So we start inpatient with fall assessment. We also have outpatient balance and fall screening programs that are very, very popular. We run these at 3 hospitals every month, and this looks at it's offered to community ambulatory adults who get the wrist ultrasound. They get some basic evaluations for balance, fall prevention, and fall recovery, and then educational material surrounding all of those. These are very, very popular. And what we also found is that our trauma accreditation gets credit for this program, because trauma falls in elderly patients, are the leading cause of trauma. It's not automobile accidents, it's older people falling. And so they have a requirement in their accreditation criteria to provide injury prevention. And so in our institution, we get two benefits within our institution. But then we have a higher level of patient who want to do exercise to maintain strong bones. And so we have a very popular 4-day-a-week free exercise program with special emphasis on weight bearing and balance training. And as I said, we work closely with other departments to share the risk, the resources, and the revenue. So I already mentioned our trauma accreditation gets some benefit from our programs. Our acute rehab center gets some credit for their CARF accreditation. Our skilled nursing facilities is able to use our ultrasound testing and our attention to treating osteoporosis in their metrics. Any of our associated physicians who see these patients can use our data to document and fulfill any of the PQRS requirements. And of course, we work very closely with our physical therapy, outpatient department, and home health nursing. So in a typical day in our facility, our hospital discharge planners or providers can order a fracture liaison consult. And if they forget to do that, we run a query on a monthly basis of the discharge fracture codes. Our fracture liaison nurse sees the patient, performs wrist ultrasound, and communicates with the primary care doctor via letters. Any team member, the pharmacist, physical therapist, or nurse or provider, can request service virtually at discharge for home health, imaging, or medication reconciliation. And then, as I said, our fracture liaison nurse goes to the skilled nursing facility every week to perform wrist ultrasounds and consult with the geriatric pharmacist for medication recommendations and community follow-up. Our limitation is that we don't have a separate mid-level provider to be the prescriber for DEXA or medication. That responsibility falls back on the primary care doctors, and that is the limiting factor in the effectiveness of my osteoporosis program. So what we want to do is go back to our steps, and in our steps, our next topic is to initiate treatment and monitor adherence. And so with that, we're going to look at calcium and vitamin D supplementation as needed, FDA-approved medications, and I'm repeating again that if you discuss the risks and benefits of treatment and not initiating treatment and the patient declines treatment, you want to document that. You'll still get metric credit if you document that it was discussed, declined, and why it was declined. Lastly, we need to communicate with the providers that we are providing all of these services for identification, evaluate, and treatment. And then, boy, here's the big task. We have to organize it all. So we want a registry that can be very simple. It can be a spreadsheet. It can be a homegrown access database. It can be a custom elaborate program like Dr. Rick Dell did for Kaiser. It can be semi-custom, like I designed with quality improvement modules through our Cerner or Meditech, and we also report through Midas. Or it can be a turnkey operation provided by Own the Bone, Protect, FLS, or a CE City registry. This is the part now where I'm going to just briefly show you the screenshots and not really go into the details, and that you can peruse this at your pace later on. So the American Orthopedic Association has a product called Own the Bone, and it's a web-based patient registry, and it fulfills all of the items that I discussed in starting an FLS, because all in one product. So you're going to data gather, you're going to record, it's going to make recommendations to the patient, recommendations to the physician. It's going to give you your measurements back, and it's also going to benchmark you against other users of the system. And so if you look at the 10 process measures, you'll see that we've discussed these all in the steps to setting up an FLS. So these are the key criteria that you will process and document and benchmark. Now, the National Bone Health Alliance in CE City now has a product called Ostonics, the Protect Fracture Liaison Service, and this is a cloud portal to manage patients' performance and quality related to osteoporosis-associated fractures. And you can see it has a beautiful home page where it will provide you with tasks, performance, improvement, and data. Oops, we're getting, let's see here. Looks like, I'm sorry, it looks like I've got some built-in, here we go. So in the old days, we used to have yellow sticky notes all over the office reminding us what to do, and we had Outlook calendars and paper calendars. Now your tasks can be all oriented in one place. All of those process measures that we talked about will be captured here, and they will help you monitor them. It will show your improvement, and it will provide the letters and the mailings for your coordination of care. There's another option, which is a registry that allows you to gather your information from your criteria and your metrics, and then bundle them for submission to the insurance providers that you may be seeking either accreditation or metric incentives from. And so these are the measures available for processing, and we'll discuss those a little bit in the next couple slides. But it suffices to say that this bundles up all the different standard of care that we should be providing and the patient should be receiving, and then allows us to put them all in one place for submission to the Qualified Clinical Data Registry. And so it looks very similar to the first product I showed you, Protect, where it's a dashboard. You get performance scores. You can continuously monitor your performance. It will show you opportunities for improvement and resources such as handouts and letters and educational materials to improve and close your measure gap. And the measures that I keep referring to are quality measures that you can document and submit through your electronic medical record. And so if you're in an outpatient setting and you're using an electronic medical record, these would be the examples of measures that you could obtain credit for by doing the proper care for your patients anyway. So measure 45 is saying that if you document that you communicated with the physician managing the ongoing care after a fracture, you can get credit, okay? So that's why in previous slides I showed you that you needed to send a letter or discuss with the primary care doctor or the orthopedic surgeon. That is an important measure because it shows that you're handing off, okay? Measure 46 is screening therapy. So this is documenting what percentage of female patients over age 65 who have had a central DEXA or are on pharmacological therapy for osteoporosis. So again, we're doing this every day. If you want to check this box and submit it for your core measures in your PQRS, then these are the measures that you would look at. Osteoporosis management following a fracture is very similar, except measure 48 says if the patient has experienced a fragility fracture, was a DEXA ordered, or was pharmacological therapy initiated, okay? So again, this is why we gave you the list of criteria for submitting a query, because you want to be able to ultimately submit your performance. For men and women age 50 or older with documented osteoporosis, either by fracture or by radiological imaging DEXA, are they being treated within 12 months? And again, falls risk assessment and falls plan of care. If you're doing this in your office, these are the measures that you want to submit for credit. Now, for HEDIS or Medicare 5-star, which is basically Medicare HMOs, you have different measures. They're basically the same version of the previous measures. They're just a different age range, and they're a different metric number. So these would be, if you were a healthcare plan or you shared risk for healthcare services, these would be measures that you would submit. Now, I just saw that there's an error on this slide. These are the National Quality Forum and the Joint Commission osteoporosis measures, which were passed. And I wrote on here they had the potential to become a new hospital accreditation core measure. I don't think that's going to happen, but these are the Joint Commission measures that the people at the NOF and the NBHA worked very hard to get approved. And so basically, these would be the measures that would be submitted for patients age 50 and over who had a fracture, and if they had appropriate laboratory services for secondary evaluation or underlying causes of osteoporosis. So this is good basic care we should all be doing and submitting for metrics. Now, the other one is the number of patients who fractured who have either a DEXA ordered or an FDA-approved medication ordered, or they are seen or linked to a fracture liaison service. So this is where you all come in. If you have a fracture liaison service and a fragility fracture patient is referred to you, then the institution or the referring physician can get full credit for this measure without having to do all that work themselves. They didn't have to order the DEXA, order the medication. They could just refer them to your fracture liaison service. And again, David reviewed with you that all of this information and webinars are available online at the Fracture Prevention Central. And I know this was a wild ride. We put a lot of information in, but I wanted to make sure that we saved time for questions. And so I'm going to put my information up here, and now I'm going to look at the first question that I see that was submitted through the National Bone Health Alliance. The question is, do you do DEXAs and ultrasounds while patient is in hospital and have no problem with reimbursement? Okay, so the patients are in the hospital for such a short amount of time, I mean at the most 3 days after even a hip fracture, and they're in pain, and our DEXA facility is actually in an outpatient part of the hospital. So the first answer is no, we do not get DEXAs while the patient is in the hospital. It's just physically impossible. We do the wrist ultrasounds. The wrist ultrasounds only reimburse in our area, I want to say something like $9. So we do not bill for the wrist ultrasound. We do that as part of this quality improvement project in our fracture liaison service so that we do have a documented risk assessment, and that information goes back to the primary care doctor or to their treating physician who will be managing their osteoporosis. The other reason we do that wrist ultrasound is because more than half of our patients go to a hospital-affiliated skilled nursing facility. It's actually got two parts, a subacute facility and the skilled nursing facility. And so we are able to get about 60% of our information in that one location, and that's why our nurse goes over there with the wrist ultrasound machine. And again, we don't charge for that. We wouldn't get paid for it anyway because it's part of a global fee or the DRG for the hospitalization. But it was an investment that we made several years ago, and it's been very, very popular. Okay, so let me see. Debbie, do I have any other questions either on the phone or are we doing them on the chat line?
So under questions, there's two more. One from Abby, one from Bradley. And, oh, two more came in.
I'm sorry, I don't see questions, I see chat.
So right under webcam is questions, and you can, so drop down. So Bradley's asking, what is being done for patients prior to a fracture? Have you found an effective way to get the FLS involved much earlier, prior to a fracture occurring?
Right. So to answer that question, we are doing a lot of community outreach. So we have a physical therapist and a nurse who take their show on the road. They go to every opportunity they can, every health fair, every gym, every church program, to give a brief 15-minute overview about osteoporosis and fall prevention and fracture prevention. I continuously give CME at all of our institutions, and we use every opportunity that we can to give patient information at our DEXA facilities. All right, let's see here. Okay. Is this service nurse driven? Okay. In our institution, it is, I'm the medical director for our program, but all of the hard work is done by our nurse and by our physical therapist. Currently, we do not have a nurse practitioner or a physician's assistant, and that is the best model. We're working very hard to lure a nurse practitioner to help me out with this, because in our specific situation, we're missing the ability to prescribe the medications and order the DEXAs because our clinic is separate from our hospital. So we're working very hard on the model of having a nurse practitioner or a physician's assistant. Let's see, what is the cost of the wrist ultrasound machine? We bought ours many, many years ago, and I don't even want to give any misinformation. It's called, it's made by Beam Med, and it's called a Mini Omni, and we can get you the information on the vendor. Okay, so the question about the wrist ultrasound machine, is it equivalent to a DEXA? The answer is no. What it's doing is it's been validated in very large studies in Canada for giving a fracture risk in women. I do not find it to be as helpful, and I find some errors in older men, but it is validated for risk assessment in women, postmenopausal women. A T-score on a wrist ultrasound, just like a T-score on a QCT or a T-score on a heel ultrasound, is not an equivalent T-score to a DEXA. And remember, the DEXA T-score is what is used for the World Health Organization definition of osteoporosis. So it's going to give you a fracture risk, but it's not going to give you an equivalent T-score. So we have a little informational sheet that we give to the referring providers and the patient when they have one at a health fair. And it basically says anything less than a -1 on this service warrants further evaluation with the traditional DEXA. So we use it as a true screening tool to get patients back to their doctor, start the conversation, and get them into the DEXA machine. Okay, and Debbie, you want to unmute Abby?
She's unmuted.
Hi, Abby. What can I answer for you? I don't hear anything, Debbie.
She might be muted on her end.
Okay, Abby, if you can hear me, see if your phone is muted. Otherwise, I can't hear you. Okay. Anyone? Trying to keep, I know a lot of you are on lunch, so I'm trying to keep this to our commitment of a noontime webinar. Okay. Okay, let's see. Abby says, I'm muted and I'm in my office and I don't have a microphone. Okay. Abby, are you able to type in a question? And then that'll be our last question. Nope. Okay, I want to make one last pitch. Let me just show you additional resources. The information that I gave was a very broad overview. We give entire half-day seminars on this at the National Osteoporosis Foundation annual meetings. And so a very good resource to help you walk through this at your own pace is the International Osteoporosis Foundation has a website called capturethefracture.org. And these are screenshots that show you step-by-step how to get started. It goes through all of the criteria that I discussed today and had in my slides in a very nice format. And you'll see that this process is the subject of a future webinar similar to this one. And you'll have a jump on it if you review this information at the International Osteoporosis Foundation. So this will be included in my slides as screenshots to help you look at opportunities, but the original material, again, is located at capturethefracture.org. All right. Well, thank you all for attending. I know it's hard to give up a lunch break to listen to a webinar, but we hope this is helpful. We appreciate any feedback that you have, and we look forward to your participation in the upcoming webinars. Thank you, and have a nice day.